I'm really excited to have you all here today and to welcome Dr. Edythe London. Do want to make a note that our seminar is being recorded for distribution on our media channels. I want to share a little bit with you about our mission at the National Center for Wellness and Recovery, which is to inspire hope and develop innovative evidence-based interventions to improve the lives of those living with pain and substance use disorders. And we do this by investing in training, treatment programs, and research for every stage of life. While we're on our call today, I do expect that you will keep yourself muted when you're not talking and there's no questions. If you do have questions during the talk, feel free to put those in the chat. We can get to them at the end of the talk. I don't expect Dr. London to be keeping up with that during her talk, but if there's a point in time where your bandwidth is low and you need to turn your video off, feel free to do that. It is nice to have videos on and see your participants engaged. So if you're able to keep it on today, please do so. I do want to note our speaker next month is Dr. Susan Tapert, who's professor of psychiatry at UCSD. She'll be speaking with us about the neuroscience of alcohol in adolescence and really talking about how brain system development is occurring during adolescence and how heavy alcohol use may influence that developmental process. So we're looking forward to that talk next month. But today we have Dr. Edythe London, and she's a professor of psychiatry and behavioral sciences at the Semel Institute for Neuroscience and Human Behavior at UCLA. And before joining the faculty at UCLA, she was director of brain imaging at NIDA. She's held faculty appointments at University of Maryland and Johns Hopkins School of Medicine. Dr. London is a pioneer in brain imaging to study addiction and uses multimodal brain imaging to reveal neurochemical and circuit level abnormalities that can inform evidence-based treatments for addiction. Her work bridges psychiatry, pharmacology, and neuroscience. And the trajectory of her research includes several notable firsts. The first to map drug-induced euphoria and drug cravings in the human brain, the first to visualize the cerebral distributions of actions of abused drugs, and the first to develop probes for external brain imaging. Her recent work provides potential therapeutic targets for addiction by focusing on cortical striatal circuitry, dopamine receptor signaling, and executive functioning. So without further ado, I will stop share, turn it over to you, Dr. London, let you take it away.
Thank you so much, Julie, for that introduction and actually for giving me an opportunity to address the group. Clearly, when I listen to the mission of the National Center for Wellness and Recovery, it sounds like the mission of my life. And what I've been doing for the past, I guess 35 years or so is following that mission with a focus on stimulant use disorders and tobacco use disorder. And today we'll be going over some of this work and what it means with respect to methamphetamine and the brain. So I think you probably already know that we're in a tremendous epidemic right now with drug overdoses. And in 2021, sadly, in this estimate ending in April of 2021, we topped 100,000 deaths. And it was largely influenced by the opioid epidemic. And the number that includes all drugs, includes opioids, stimulants, and others. But in fact, the rise in synthetic opioid availability, particularly fentanyl, coming ultimately through Mexico, but originally largely in China, has done terrible things to our humanity in the United States. Now, we're talking about stimulants, and the reality is that although you have over 100,000 deaths, largely due to the availability and the use of opioids, 21% are due to cocaine, 21% almost also due to psychostimulants, primarily methamphetamine. So it's important for us to see the trajectory of overdose deaths due to stimulants per se. We're talking about 20% of this 100,000 due to cocaine and 20% due to methamphetamine primarily. But take a look at the trajectory that has gone on since the year 2000, especially between the year 2013 and really up here 2019, 2021. There's been a huge soaring increase in overdose deaths due to psychostimulants. Now, to some extent, the psychostimulants are combined with fentanyl. Often people die of overdose when they're thinking that they're taking only methamphetamine, and it's methamphetamine laced with fentanyl or some other contaminant. But we see a tremendous need for treatment of psychostimulant abuse disorders. Now, there's also contributing to this increase in deaths, the methamphetamine that's available on the street is stronger, purer than what was available before. So it's really a very difficult, complicated situation that's doing really awful things in our society. So when we're thinking about developing evidence-based treatments, we have particular targets. We have problems in thinking that people have, especially during the early abstinence phase, although there is some recovery. We have, with respect to cognitive problems, there are problems with inhibitory control. Individuals who have methamphetamine use disorder will say that they sometimes, when they want to reduce their dose or reduce the amount that they're using, they have difficulty doing that. If they want to stop completely, they have difficulty doing that. But it would be wrong to think that inhibitory control is completely disordered, because it takes an awful lot of planning to procure an illicit substance, to hide it from their friends and family, and sometimes to try to have a job and work while they're having this substance use disorder. There are problems with decision making, and these problems interfere with a person's ability to take part in treatment. Now, there are other problems that we can talk about, but the cognitive problems, if they're addressed, they really could help somebody engage in treatment and stay in treatment. In addition to these cognitive states, we have emotional states that are particularly difficult when someone initially stops taking methamphetamine. They have problems with negative affect, anxiety, depression. They have intense craving for the drug, and they have withdrawal symptoms. The withdrawal symptoms involving problems with sleep as well as these emotional problems. So what we've been doing in our research group is using brain imaging to identify the neural targets of substance use disorders. We study brain structure and function, and this picture shows brain stimulation as a new potential therapy. For stimulant use disorders, although there are medications that are helpful, and addiction psychiatrists will say that their go-to drugs when somebody comes with a stimulant use disorder would be something like modafinil or bupropion, but these behavioral treatments don't help everyone, and they're really off-label treatments. And the most important, the most widely used treatments are the behavioral treatments, such as cognitive behavioral therapy or contingency management. Well, cognitive behavioral therapy requires that the patient or client be able to engage with the treatment program, and this may require some therapeutic approach to improving cognition. So we use brain imaging, and brain imaging helps us understand how specific areas of the brain or specific circuits are important in a particular function, like memory. Certain kinds of memory may involve certain areas of the brain, which would then be the therapeutic targets for someone who has a targeted or specific memory disorder. And imaging also helps us identify what parts of the brain are affected. In the case of what we'll be discussing today, we'll be talking a bit about the circuits and the brain regions and the chemistry that is affected by methamphetamine. And if we can identify these abnormal biochemical processes, we can develop new strategies. If they're biochemical processes, the new strategies could be medications that target those specific biochemical processes. But the goal of all of this really is to help understand really what's wrong. So what is it that we're trying to change? And with the new advent of non-invasive brain imaging, non-invasive brain stimulation, the imaging gives us a way to target certain regions or circuits of the brain that might be particularly helpful. Now, I know this is a group of people that is together today with a lot of different backgrounds. And so I thought I'd say a little bit about the techniques. One of the big techniques that we use is magnetic resonance imaging. It came out, it started being important in structural studies and even in the 1990s. And then it was advanced to functional studies. But it's physics. And what happens is in a magnetic field, and when someone is in a room that has the magnet is usually always on, but protons, like hydrogen atoms, charged hydrogen atoms, precess, they spin along their little axes within tissue. And then a radio frequency pulse is applied, zap, and then they line up. But then when they release their energy, when they relax and go back to this state when they're happily precessing along their axes, this energy is released. And when that energy is released, that signal that's released is recorded, and a computer system can construct an image of where the energy came from. And we get these beautiful pictures of brain structure that look amazingly almost like fresh tissue. So here you see the corpus callosum, the cerebellum, and the area that we're going to talk an awful lot about, the striatum, which is important in inhibitory control, reward, and it has a lot of connections with the cortex. So MRI came alive when I was a very young scientist, and it's really changed the way we do things. Now, this is a study that was just completed in my lab by Johannes Petzold and the group. And here what we have are the results of really the largest study comparing people who are in early abstinence from methamphetamine as compared to controls. We have almost 90 people in each group. And these colors these orange and red colors show where there is a significant difference between the individuals with methamphetamine use disorder and the healthy controls. And you see effects in very important areas of the cortex. The orbital cortex, which is very important in judgment and decision-making, the superior frontal gyrus, the temporal cortex involved in estimation, the insula, this little area that is also very important in decision-making, the anterior cingulate, which is important in self-monitoring, and the precuneus, which has a role in craving. So you have these little red and orange dots showing you where, on average, a group of 90 or so people with methamphetamine use disorder, during the first week or so, when they're abstinent from the drug, so they have no drug on board, but they haven't really had a time to recover. So we see how they're different from people who have never used methamphetamine and are matched for age and demographics, socioeconomic status, smoking, cigarette smoking, which also affects brain structure. And it's important to evaluate these parameters in brain during early abstinence, because that's when people are approaching a treatment episode. It's not when they're out 2.5 years. And what we have done with colleagues in China, where they've had people in compulsory treatment for years, what we can see is that there's recovery, and that the recovery is really kind of slow. So we have men and women, and this is the orbitofrontal cortex, one of those areas that shows smaller gray matter thickness in early abstinence. And these people are abstinent over 2 years, right? And what you can see is that you have a significant increase in volume. So things are getting better. We don't know the extent to which this increase is linked to the functions that the orbitofrontal cortex subserves. That has yet to be tested, but you can imagine that it's very, very difficult to identify a group of people who have been abstinent from heavy methamphetamine use for over a year or two. Now, this recovery in the brain isn't the same in all areas of the brain. The anterior cingulate cortex, which is important in mood states, but also in self-monitoring, it doesn't improve at the same rate as the orbitofrontal cortex. So there is recovery in the brain, recovery of brain structure, and we would imagine that with recovery, cognitive performance improves. And we've, in fact, in our laboratory measured recovery to some extent, not 100%, but some recovery even during the first month of abstinence. Now, one of the first findings that we had with brain structure is this article that came out in 2004. And here you're looking at the lateral surface of the right and the left hemisphere. And these colors are representing the percent difference between a group of individuals with methamphetamine use disorder and people who are healthy controls that have never used the drug. So these are difference maps. And so we have an average percent deficit in the individuals with methamphetamine use disorder. That's small, but significant. And this area that I've circled in yellow is the right Inferior frontal gyrus, the problem is more substantial on the right than the left. And again, these are people who are abstinent very early in their abstinence, 4 to 7 days. I think there were a few that were abstinent 11 days, but less than 2 weeks. So these are early abstinent people with this small but significant deficit in the right inferior frontal gyrus. And that's an area that is of tremendous interest because it's shown in people who have disorders such as Parkinson's disease, where there is, in fact, some degeneration in that region of the cortex, that there's a relationship between the cortical volume, the gray matter volume in that area, and their ability to inhibit motor responses. So motor response inhibition is not what we think of as the kind of inhibitory control that we see in people with stimulant use disorders, but we have shown that motor response inhibition is highly correlated with other kinds of inhibitory control that are emotional and important. And here we have like a laboratory test where we can evaluate a person's ability to regulate their motor response. A stimulus is shown on the screen, and the instruction is push the left or the right pointing arrow as soon as you see it. And the response is measured, like how long does it take for them to push the button. And that duration is called the go reaction time. How long does it take for someone to just do something? But on 20% of the trials, there's a little beep that comes out. And this auditory prompt means don't push the button. You need to inhibit your response. And a computer program is generated to move the timing of that beep for the individual based on their performance. So if the beep occurs very early in the trial, like as soon as the stimulus appears, it's easier to stop. But if the beep appears later on, closer to the person's go reaction time, their finger's just already almost on that button. It's harder for them to stop. The action is already underway. And we determined the 50% time, which is the time, the lag between the appearance of the visual stimulus and the auditory prompt, where each individual would be able to inhibit about 50% of the time. And we call that the stop signal delay. And the difference between the go reaction time and the stop signal delay is the stop signal reaction time. Now, I went through all of that just to tell you that the stop signal reaction time is what we care about. It's a measure of how long it takes for someone to be able to stop. And it's the kind of inhibitory control that you need if you're driving and a child runs in front of your car. You really need to stop right away. And that's the kind of inhibitory control that we're measuring. So individuals with methamphetamine use disorder have a problem. They really shouldn't be truck drivers until they've recovered, because their stop signal reaction time is substantially longer than that of an individual who hasn't used methamphetamine. Again, this is during the 4 to 7 day abstinence period. Recovery is something that we really, can offer people and encourage them to think about. And the amount of drug, this is grams of methamphetamine. This is log of grams of methamphetamine that they generally use the week before evaluation, is highly correlated with the stop signal reaction time. So stop signal reaction time is something that you want to have small. And the methamphetamine use disorder clients have a longer stop signal reaction time, and it's related to how much drug they've been taking. Now, we don't know for sure if their stop signal reaction time or some measure of inhibitory control led them to take more drug, or if taking more drug produced an impairment in their ability to stop. But as I said, it's important to think in terms of what this region of the brain that we're studying, the right inferior frontal gyrus, is related to. So the physical measure in the MRI scan is gray matter intensity that we used at that time. And the greater the gray matter intensity, the healthier the right inferior frontal gyrus, the less craving somebody reports during this first week of abstinence. So the structure of the right inferior frontal gyrus, which is related to motor response inhibition in patients with Parkinson's disease, is related to craving for methamphetamine in patients who are in the hospital and know that they can't really have methamphetamine. And craving for methamphetamine is highly correlated with stop signal reaction time. And what we've learned from this and related studies is that the right inferior frontal gyrus, that area of the brain, is important for control of all sorts of emotional and cognitive states. And therefore, that deficit in structure of the region could be fundamental not only to a person's planning ability, but also their physical, their emotional state and craving when they are approaching a treatment episode. Now, aside from the cerebral cortex, I think everybody knows that the hippocampus is important in memory, and that it is an area of the brain that's particularly affected in Alzheimer's disease, right? And here, Paul Thompson measured the volume of the hippocampus in a control group and a group with methamphetamine use disorder. And whether it's the right or the left or the average, you see about an 8% loss of hippocampal volume, which is consistent with early Alzheimer's disease. And we haven't measured recovery of the hippocampus yet, but we would imagine that there is some recovery as well. Now, this deficit in the volume of the hippocampus was measured in a different way. And this pretty picture tells you something about how Paul went about measuring, making measurements in the hippocampus. These little arrows from the center point out radially. And therefore, what he was doing was he was measuring the radial size of the hippocampus at different areas. And the hippocampus, you know, the word means seahorse, and it's shaped a bit like a seahorse. And here, what you see, these colored areas, this red area, it's not the entire hippocampus that's involved, but these sub-regions of the hippocampus that are colored red show a really interesting relationship between atrophy compared with control and recall in a memory test. People are given a series of words with a delay, and then they're asked to recall the words. So a couple of the deficits that we've seen and would like to address are inhibitory control and memory, each of which are very important in a person's ability to engage in treatment. Now, in addition to magnetic resonance imaging, we use positron emission tomography, PET scans. And the first PET scan became commercially available in 1976. And it's different from MRI because it's a nuclear medicine procedure. That means that radioactivity is involved. And so the person receives a compound of interest, something you really want to trace, and it's tagged with a radioactive nuclide. And then they're in what looks like a washing machine for people. They're sort of inside. And the gantry around the person has detectors. And these detectors are sensitive to essentially light. And what happens is the radioactive molecule, when it becomes, it's radioactive so that it can achieve stability. And as it achieves stability, what happens is it sends a molecule out of the atom called a positron. And these positrons interact with electrons, and every time that happens, there is a light, photons sent at 180 degrees in two directions. And these detectors pick up these coincidence events, like when they pick up when you have two photons hitting at 180 degrees at the same time. And those events tell you where the tracer went, right? The tracer is accumulated according to whatever biochemical process you're interested in. And then what happens is you get these detectors are hooked up to a computer system, which is going to reconstruct an image of where the radioactivity came from. So a compound is injected, it gets incorporated into the brain, depending on how that compound is used biochemically. And then a computer system is going to reconstruct this image showing you where the radioactivity accumulated in the brain. And the most useful tracer that's ever been used for PET scanning is fluorodeoxyglucose, or FDG. It's used a lot in cancer research, but it's also used because the pictures of where the fluorodeoxyglucose got incorporated is a picture of how fast the brain is using glucose. And these red areas, for example, are using glucose more than a green area. And the glucose is used in proportion to neurons firing. So the uptake of this tracer is giving you a picture that's proportional to brain activity. And we can use that to understand how brain activity is related to how a person feels. And so we know that during the first week of abstinence, very high depressive ratings. I mean, look, you're going up to, in some people, a Beck depression inventory score of 18. That's pretty bad. You know, when we see a score of 18, I call a professional to try to talk the person down and see if they need something else. They also have high anxiety ratings. And again, it's related to the recent use of methamphetamine. The individuals, as individuals report higher use of the drug, they are the ones who are the more depressed individuals. They're the ones who have the greater anxiety. Who knows? Maybe the anxiety and depression drove them to take the methamphetamine, or maybe the methamphetamine exacerbated a condition that was already there. But in any case, we know that the depression and anxiety are indeed therapeutic targets that influence a person's feeling state and how they're going to do in treatment. Now, we've used fluorodeoxyglucose, FDG and PET scanning to show differences in the brains of people in early abstinence from methamphetamine and healthy controls. I just got this terrible message that says my internet connection is unstable. It scares me a lot, but let's keep going.
We can hear you just fine.
So far, we're okay. But take a look at these images. The colored areas are essentially what we measured with the PET scan superimposed on a structural image with MRI, just so that you can see a little bit better where these functional differences are. And again, these are difference maps. This is a comparison of a group of individuals with methamphetamine use disorder in early abstinence and a group of healthy controls. And red indicates that the individuals with methamphetamine use disorder have higher metabolic rate in those areas. And what you essentially see is that the amygdala and ventral striatum, but especially the amygdala, have a very, very high metabolic rate compared to healthy controls. The amygdala is really important in the limbic system, in fear, in negative feeling states. And what you also see, these blue areas, the cool areas, are where individuals with methamphetamine use disorder have less activity than healthy controls. And you see less activity in the anterior cingulate cortex, an area that the dorsal anterior cingulate cortex I mentioned earlier is involved in self-monitoring. It's involved in inhibitory control. But you also see this area below the corpus callosum, the subgenual, below the genu. This subgenual anterior cingulate cortex is particularly affected in major depressive disorder. So you really see a picture of the individual with methamphetamine use disorder when he's first coming to treatment of an overactive amygdala and an underactive anterior cingulate. And essentially, you see kind of a loss of control of the amygdala. When we measure depression on the Beck Depressive Inventory or anxiety on the Hamilton Rating Scale, we can evaluate how these emotional states are related to activity measured as glucose metabolism. And what you can see is that whether it's depression or anxiety, there is a positive correlation. The higher the activity in the amygdala, the more depressed a person is, the more anxious a person is. Now, these maps represent the correlations in a group of 19 individuals with methamphetamine use disorder. There's a negative relationship between anxiety and prefrontal cortical areas. So the lower the activity in the prefrontal cortical area, the higher the activity in the amygdala, the more anxious a person is, indicating that these regions of the brain are targets for interventions that may alter firing rates. And you know, right now there's transcranial magnetic stimulation that's used for depressive disorders. In fact, insurance will pay for it. And the target that's mostly used is the dorsolateral prefrontal cortex. But as these techniques become available, we're learning more and more about what the appropriate targets are going to be for individuals. And as the techniques become more and more localizing, they become more useful. You might think transcranial magnetic stimulation only hits surface areas, but with focused ultrasound stimulation, which we're experimenting with, we've also seen that it's possible to selectively stimulate the amygdala and reduce anxiety in people with anxiety disorders. These are preliminary data. So we said a little bit something about impulsivity, and we know that impulsivity is a problem in people with all sorts of addictive disorders, whether the disorders are drugs, food, or behaviors such as gambling, right? There's a lack of self-control, and impulsivity, the way we're examining it, aside from the lack of inhibitory control that you can measure in the laboratory, impulsivity reflects kind of how a person sees himself acting in the world. It's measured on self-reports, such as the Barat impulsiveness scale, where the items reflect things like thinking before acting, or lack of thinking before acting. And on the Barat impulsive scale, in addition to these cognitive measures like I act before thinking, there are also behavioral measures that refer to hyperactivity, the kind of hyperactivity, motor hyperactivity, fidgeting that's seen in ADHD. But in a fairly large group of individuals with methamphetamine use disorder compared with matched healthy controls, on the self-report measure, the individuals with methamphetamine use disorder, whether it is the cognitive subscale or the behavioral subscale, they see themselves as, they feel themselves as being more impulsive. And in fact, their impulsivity score is higher when they are when they're abstinent from methamphetamine for a week as compared to when they first come in, suggesting that the methamphetamine in part is reducing this lack of control. So we can also use positron emission tomography in addition to measuring brain function with fluorodeoxyglucose, that measure of glucose metabolism. We can evaluate the density of specific receptors for neurotransmitters. And we've been focusing on dopamine receptors, the D2 dopamine receptors, and you get a different kind of picture. You have this area of the brain is the striatum, the caudate, the putamen, and this very bright area represents the fact that you have an awful lot of D2 type dopamine receptors right there in the striatum. You have them elsewhere in the brain, not pictured here. You have them in the hippocampus at a higher concentration than in the cortex, but they're also in the cortex in measurable concentrations. And here the tracer we use is labeled with fluorine 18. So we give an injection of F18 phthalate. The phthalate is incorporated and binds to the dopamine receptors, and the PET scan will tell us where the tracer accumulated, and that'll give us an indication of how many receptors that person might have. And we know that individuals with methamphetamine use disorder have about a 14 or 15% deficit. I don't want to call it a loss, but it is a smaller amount of dopamine receptors available for the tracer to bind to in the three areas of the striatum: the nucleus accumbens, the caudate, and the putamen. And what you're seeing here is the areas where, in fact, there is a group difference between healthy control individuals and individuals with methamphetamine use disorder. So it's a 14 or 15% deficit, pretty much, but that's enough to make a difference. And when measuring impulsivity on the Barat impulsiveness scale, you see these colored areas are the areas where there is a significant relationship between receptor binding and the self-report of impulsivity. More so in individuals with methamphetamine use disorder than in the healthy controls. Here, in the caudate and putamen, what you see is a strong relationship, so that the lower the receptor availability, the higher the self-report of impulsivity. So loss of dopamine receptors in the striatum could be a major source of impulsive behavior in individuals with methamphetamine use disorder during early abstinence. In healthy controls, you also see a relationship. It's significant, it's the same direction. The more receptors, the less impulsive. But here what you see is the statistical significance is restricted essentially to just this little ribbon of tissue in the lateral and the putamen. And the reason for the stronger dependence on D2 dopamine receptors, I could infer, has to do with the fact that healthy control individuals, they have plenty of receptors. They have spare receptors. They don't need them all. Individuals with methamphetamine use disorder, with that 15% deficit, those receptors are more meaningful in modulating impulsive behavior, or at least the feeling state that someone has that makes them report that they're impulsive. The dopamine receptors are also related to the stop signal reaction time in a negative way. So those people who have the largest concentration of dopamine receptors in the caudate putamen, they have the slowest stop signal reaction time. So low stop signal reaction time associated with high receptor number. That's a good thing. And here, this map shows superimposed on a structural scan the areas where this relationship between dopamine receptors and ability to stop are in fact highly correlated. Now I'd like to talk to you about this model for how dopamine might have something to do with inhibitory control. And there are two interacting systems in the striatum, and they are systems that are driven by D2 dopamine receptors, which really show a deficit in individuals with just about every substance use disorder that's been studied. D1 receptors, which don't. And there's a difference between the D2 and the D1 receptors. The D2 receptors that we've been talking about are very high affinity. They don't need a lot of dopamine in the extracellular space to activate them. And they are modulatory, and they are involved in inhibiting the effects of D1 receptor stimulation. The D1 dopamine receptors are low affinity, and they need a burst of dopamine to turn them on. And when there is imminent reward in the environment, for example, the ability to self-administer drug, there is a burst of dopamine which is adequate to activate these D1 receptors, which ultimately influence corticospinal pathways by going through the substantia nigra, globus pallidus interna, ultimately inhibiting thalamic stimulation to the cortex So you have ultimately in disinhibiting the thalamus so that you have more activation of the cortex and driving of the corticospinal pathway. The D1 system, it's the go system. It's the system which, when activated, the organism says, oh my God, something important just happened. I need to do something. But what do I do? And the D2 system is more important in helping the organism select from a series of possible responses what's the right one. The D2 system is an inhibitory system, a modulatory system, and it goes through an indirect pathway to the globus pallidus pars interna through the subthalamic nucleus. That's why it's called the indirect pathway. Ultimately, inhibiting thalamic activity, reducing stimulation of the cortex, allowing the organism to stop and think before we act. And we've measured the availability of the D2 dopamine receptors, and I showed you those data. This is your 15% deficit of D2 receptors in the striatum, measured with phallipride, the tracer that I mentioned. But then we have another tracer that we can use to measure D1 receptor availability, and there's really no significant difference. And so these pictures show a slightly less bright striatum for D2 receptors and no difference at all for D1 receptors. This is bad because what this means is you perhaps have an imbalance between the direct and indirect pathways. What would you like to do? You would like to reduce the D1 activity to some extent, maybe, maybe not. But what you might really want to do is augment this modulatory system, the D2 system. Now, we talked about impulsivity and the D2 dopamine receptors. I'd like to mention memory a little bit. And here, what you can see is that episodic memory and also spatial working memory show some differences, but there's only a significant difference in episodic memory. And this is related to the D2 dopamine receptor availability in the hippocampus. I'm just showing the left side, and what you can see is a very strong relationship between D2 dopamine receptors in the hippocampus and episodic memory, and a trend that may be significant with a larger sample for spatial working memory. However, spatial working memory is much more related to dopamine receptor binding in a variety of cortical areas. And here we show the relationships in the occipital, frontal, and temporal cortices, and I've just circled them. The idea is that the greater the dopamine receptor availability, the greater or the better the performance in a spatial working memory task. So dopamine receptors in the striatum, as well as the hippocampus and cortex, are fundamentally important for a variety of cognitive tests. And we're going to talk a little bit now about decision making, which we model in the laboratory. We use tests in the laboratory that model real world decisions. We have a judgment on delayed discounting tasks of, would you rather have a large reward later, or will you take a smaller reward right now? And individuals with various substance use disorders, they discount the value of a reward the further in the future it is. Maybe because they really don't know what their future is going to be, And what's more important to them is what's happening right now. A strong future outlook could help them. We also do gambling tasks and risk tasks, and I'll just talk to you a little bit about some of these. So again, with delayed discounting, it's been referred to as a test of impulsivity, although I don't believe it's a test of impulsivity. It's a test of optimal decision making. And so what happens is there is low, moderate, or high discounting. In other words, a greater effect of having a reward delayed and having that delay have the client devalue that delay. And we can also see that the degree of how much they discount this log of K, which is a measure of the steepness of discounting, is correlated with D2 dopamine receptor binding in the striatum. And the slope is greater in individuals with methamphetamine use disorder, and it's significant, but not so in healthy control. So again, this is striatal dopamine receptors influencing a decision-making task. And here's a different kind of decision-making task. This is one where someone decides on how much risk they want to take. It's the balloon analog risk task, and we can do it during functional magnetic resonance imaging. They keep seeing a balloon, and every time they see a balloon, the participant has the choice of taking the amount of money that they see or pushing the button to increase the size of the balloon, in which case they could get another 25 cents. But there's a computer program that will have the balloon burst after a certain number of pumps, and the person has to kind of interpret the fact that they're increasing the risk with each pump. Of course, with each pump, they could also get more money, so it's a balance. With each pump, what increases is what we call in gambling the stakes. The stakes get higher. You can make more money, but you can lose more money. And so we've done what we call a parametric analysis, where we look inside the brain and evaluate whether there's a linear relationship between the stakes, how high are the stakes, and how much activation is there in the brain when someone is making the decision. Do I pump, or do I take the winnings right now and cash out? And what we see in healthy people is, and every time they see that balloon, they have the choice of taking more risk or cashing out and not losing what they've got. And in healthy people, these are two areas of the brain that show a linear relationship with the stakes and how much activation. It's this area of the lateral prefrontal cortex and the insula. When someone is making the decision to take more risk, that's what's activated, and there's a relationship. When they're cashing out, when they're just right before they cash out, what happens is there's a relationship between the activity and the nucleus accumbens, which is important in reward, because they know they're getting their reward right then. This is what happens in healthy people, and it's related to dopamine receptor availability in the striatum. Both the activation of this prefrontal cortical area is during their decision to take risk is related negatively to dopamine receptor availability in the striatum. And again, when they're cashing out, their dopamine receptor availability in the striatum is correlated with how much activation they're seeing as well. It's very different in people who have methamphetamine use disorder. This area of the dorsolateral prefrontal cortex that shows a relationship between the stakes when someone is deciding to take risk, and which shows that relationship in healthy controls. It does not show a significant relationship in individuals with methamphetamine use disorder. In fact, what happens is, and this is when someone is deciding or thinking about to take the risk or not, what's activated is the ventral striatum. And so you really have a dysregulation in the association of corticostriatal function in individuals with early abstinence from methamphetamine use disorder. So because all of this is related to dopamine receptors, and we thought of what intervention can we use to increase these receptors in people who have a deficit. And so we looked at the literature, and in the rat striatum, exercise is going to increase the dopamine receptor binding. And also in rats, exercise reduces the loss of dopamine receptors due to normal aging. Also, mRNA expression for dopamine receptors increases in the mouse with exercise. And there's this wonderful study by Odell where there were rats that were receiving either saline or methamphetamine, and the animals that were sedentary showed a tremendous loss of the dopamine transporter. And that's one of the markers for the dopamine system that is impaired in methamphetamine use disorder. But animals that were exercised, they showed much less of an effect. So we thought we'd try this in the clinic, and we superimposed an 8-week intervention of either aerobic exercise and strength training or a control interactive health education program on top of treatment as usual in kind of a therapeutic community. And here we're looking at individuals in the control group from pre to post treatment. There's no significant difference in dopamine receptors. But the exercise group showed an increase in dopamine receptor availability on the order of that 15% that these individuals normally show a deficit. This exercise intervention is the only intervention that has ever been shown to increase dopamine receptor availability. It's a small study. It was 10 people in the exercise group and 11 in the control group. We're trying to replicate it. But while we've been doing that, Trivedi and colleagues had a multi-site clinical trial with an intervention just like ours, right? And this is the proportion of days abstinent. And this doesn't look all that promising. However, the effect of exercise here is on the order of what you see with any kind of medication that's ever been evaluated. And it is statistically significant if you control for adherence to the exercise program. Our study was inpatient for 8 weeks. This was a longer study that involved people starting inpatient and then going outpatient. And for sure, adherence was not what we would have liked it to have been, but it does seem promising. So what do we want to do beyond this? We want to see if an increase in dopamine receptors is really linked to improved cognitive control, decision-making, memory, and is that increase related to a reduction in the use of stimulants? And we're also looking for medications that can alter that balance of D1 to D2 because it's much easier to give someone a medication than expect them to do vigorous exercise 3 times a week. And I'd just like to say that I have been blessed over the course of my time at UCLA, which started in the year 1999, by having some wonderful trainees, some of whom are, I believe, going to be leaders in the field, and some faculty who have been with me for quite some time, and wonderful collaborators, and funding from private foundations as well as the National Institutes of Health. And I'm at 11:03, but I'm here to answer your questions if you're willing to ask.
Thank you so much. This is
Of
really
course.
amazing. No, we had one question in the chat about, well, and I wrote it down and I should just pull up the chat. The chat was when you were talking about the right prefrontal gyrus. And so the question was about development of that brain area.
Very, very important question. That area of the brain gets connected up with the rest of the brain later on in life. And there are some wonderful studies by someone named Ged, G-J-E-D or G-J-E-D-D, on development of the brain. And the reality is, and also by my colleague Paul Thompson, gray matter and white matter do different things. So the prefrontal cortex shows a thinning and a loss of gray matter with development, which continues particularly through the time that someone's about 25 years old, after they've already decided to engage in substance abuse. And the white matter tracts are developing at the same time. So you have an increase in the white matter connectivity of prefrontal regions, such as the inferior frontal gyrus, and a cortical thinning, which represents a pruning of really irrelevant or unnecessary synapses. And so the sad thing is that although there's recovery, when somebody is taking methamphetamine during this developmental period, which, you know, kind of goes through young adulthood, they may alter the trajectory of development. And I would imagine that it's more difficult to fix that than it is to recover if the insult is later on in life after this developmental period.
Okay, I have a new question. What insight might Dr. London provide to those working in the criminal justice system? How does judicial oversight help or hinder the healing process?
Well, I can tell you that court-mandated treatment works. And, you know, a lot of the, well, some of the people who I work with in treatment centers were in court-mandated treatment. And not only their own personal experience, but even if somebody doesn't have the insight to believe that they need treatment, even if they feel like they don't really have a problem, if they have court-mandated treatment, it really helps them. Not everyone, but I think it's worth doing. What about the judicial system? Oh, I don't know. I think putting young people in prison where they have availability of drugs of abuse is kind of that's a criminal thing in and of itself. There's a wonderful TV series that I watch. I don't know if you can still find it on Netflix. It was The Night Of, where anybody see it? It was wonderful. It was this young guy got in trouble, went to prison, and became a cocaine addict. And it never would have happened to him had he not been put in prison.
Hmm.
I'm sure that's a very common story.
Mm-hmm. Well, now we have a new one to look up.
The night of.
The night of. Oh, someone says it's on HBO Max. Okay, so good information in the chat here. Maybe one last question, because I know we're tight on time. What I know that in several of your studies, and you did demonstrate sort of the dose response relationship. How do you anticipate maybe some things have changed since the early methamphetamine studies in your work to now with the change from ephedrine-based methamphetamine to the P2P method of making methamphetamine?
Gee, I really don't know. I mean, I know that the doses that are available at a time are higher, but the idea that we were trying to go after was, are these problems that people are seeing related to how much they take? And I would imagine that that's still the case, although the experiments haven't been done. And I don't know that the National Institute on Drug Abuse will pay for them to be done. Replication is a good thing, though.
Yeah. Excellent. And I'm guessing that if anyone in this group would like to, they can find Dr. London's information, send her a note. You can send me a note. I'm happy to connect you. Thank you so much for joining us today and for sharing.
My pleasure. My pleasure. I would love to hear from you, and goodbye, everyone. Thank you so much.
Thank you.